Good evening, Dr. Rakesh. Shall we start? It's already
Yes,
5.
another 1 or 2 minutes. Yeah.
Okay, sir.
Good evening, Dr. Rakesh. Is Sudish is there?
Yeah, good evening, sir. He has joined, sir. He has joined.
He joined. Okay.
Yeah.
So
Maybe another 1 minute, sir.
yes.
Just let me check.
Yeah, I think he joined. Yes.
Namaste, Sudesh.
Sir, good evening, sir. Good evening. Good evening, Alok,
Good
sir.
evening,
Long time
yes.
since we met.
So welcome today to today's research and publication ISA series. Over to Dr. Kiran Mahindru from DMCS for further proceedings.
Thank you so much, sir. So good evening, everyone. It is with great pleasure that I introduce our esteemed chairperson for today's webinar on sample size calculation, Professor Alok Samantre. He is professor and head Department of Anesthesia and Critical Care at Sri Venkateshwar Institute of Medical Science, Tirupati. In his remarkable career that spans numerous accomplishments, he has received prestigious Forbes Award in the year 2006 for Best Innovative Work in Critical Care and Trauma, awarded by ISA at Mysore. Professor Satpathy Memorial Award for Best Scientific Paper in the field of anesthesia by Odisha State Branch. Andhra Pradesh State Best Teacher Award in Medical category for year 2022. Best Reviewer Award from IJ in 2017. He is currently serving as Associate Editor of Southern Edition of IJA. He has over 40 publications in various indexed peer-reviewed journals. We are incredibly fortunate to have Sir as our chairperson and guide us through this informative session. I request Sir to kindly introduce the speaker for today's session. Over to you, Sir.
Thank you. Thank you, Kiran. It's my pleasure to introduce my friend, Dr. Sudish, who is a professor at Bangalore Medical College and Research Institute. He is a very well-known figure in the field of academics, in the field of research and methodology. And he has been associated with the Indian Journal of Anesthesia as an assistant editor and associate editor for quite some time. It's almost up to 2020. He has also served as a past editor of Karnataka Journal of Anesthesia. The best way he could involve himself in this research methodology is as a part of the team from the ISA, which was leading the research and methodology workshop throughout the country. As a member of the team, he has visited almost 18 places throughout the India to make people aware of this research concept. So today he is dealing with a very important topic like sample size estimation. And we all know that too much or too less of this is not useful in the research and it will be harmful in contrary to this. So without wasting much time, I call upon Dr. Sudish, Professor of Anesthesiology, to take over this online platform and to deliberate his talk. Over to Dr. Sudish.
Thank you, Alok, sir, for your kind and elaborate introduction. I'm really thankful to you for giving such a wonderful this one about me. And at the outside, I would like to thank Dr. Rakesh Garg, our editor-in-chief, and one of my closest colleagues in this research methodology core team. And also, I'd like to thank the ISA headquarters for giving me this wonderful opportunity. So without wasting, and I here welcome, I can see some of the senior and very well-known anesthesia fraternity here who have joined this online meeting, and my greetings to all of them. And just to have one small disclosure that this is basically aimed at some elementary things, very basic things. Of course, there are things which can be discussed, but what I'm going to talk about in the initial period is mostly dealing with the basics and mainly helpful for the novice, especially for the postgraduates and young clinicians who have just started working on in the level of research. So without wasting much of a time, I think I'll share my screen and start with the proceedings, sir. I can go ahead, sir.
Yes, sir.
Yes, sir. Yes.
Dr. Aloka, you are muted, sir.
Yes, Dr. Sudhis, please start.
Sir, is the slides visible, sir? Is the slide visible?
Yeah, slides are visible.
Okay, as we all know, sample size estimation actually is one of the most important components of any research, because without having an adequate sample, the results can have far-reaching implications with regards to its validity, with regards to its significance, and also with regards to its applicability worldwide once the research is published in a journal. So therefore, sample size estimation is a must in almost all the research work, and this has been emphasized by many of the research bodies, and there is a lot of emphasis being placed on a proper sample size, selection of a proper sample size before you conduct a study. So in the next few minutes, I'll be taking you through various steps of sample size estimation, and also rather than knowing the steps, it's very important to understand that what are the important things that are supposed to be there when you calculate a sample size. So why why one should calculate a sample size? It's simple, because sample size calculations are needed to define what number of subjects, at what number of subjects it becomes quite unlikely that adding more subjects will not change the conclusion. Sorry, this small typing error will not change the conclusion. By let us say if a minimal sample size required is around 30, but if you do add another 40 patients or 50 patients, it doesn't mean that by adding more patients you are actually going to change the conclusion or change the direction of the results. It's just that it's only going to change the magnitude of the effect size or magnitude of the values, but it will never change the direction of the results. If it is going to be positive, it's only going to be positive. If it's going to be negative, it's going to be only negative. So therefore, the sample size is a minimum number of subjects that is required to provide a meaningful meaningful outcome, which is both clinically and statistically significant, or clinically and statistically appreciable. So once we understand what is the definition of sample size, now why you should calculate a precise number? Why not more or less? So the problem with the less number of sample size is that many times it might not achieve the statistical significance. And the results, many times, even if you achieve statistical significance, the results may not be consistent, especially when you go on repeating the trial multiple times. And also, there is always a questionable validity of research when you do the study with minimum number of samples. Likewise, if you take too many subjects into the sample more than what is required, what happens is, you might find statistically significant, though their clinical significance is very minimal. For us, for example, let us say the duration of analgesia, you are doing a study on duration of analgesia, and you get a group A, the duration of analgesia as 250 minutes, whereas in group B, it is 260 minutes. Because you have used a very large number, maybe 100 or 200 patients, what will happen is this will show a statistical significance. But the problem here is it clinically relevant? Somebody having just 10 minutes extra analgesia, does it really matter clinically? Isn't it? So that is a question that arises. So that is the problem with a very large sample size. And also, most importantly, it is unnecessarily exposing the population, especially if you are trying to study a new drug or trying to study the new effect of a new effect of an old drug. So you are unnecessarily exposing the population to the unknown effects or unexplored effects of a new drug. So therefore, you are actually putting the patient's life at jeopardy. So that is one of the major issues, and also it can result in greater economical and ethical burden. So therefore, all these things emphasizes that we have to calculate the sample size appropriately before conducting a quality research. So is it required only for randomized control trials? No, it's not only for randomized control trials. sample size estimation is also required for even descriptive studies and also for retrospective studies if wherever possible. Not only this, even for if you are doing something like a survey or a correlation study or anything like that, even for descriptive study, if you are just going on observing a patient for a particular effect, you are trying to assess the risk factor and effect. Even then, you are supposed to calculate the sample size, because you should know what is the minimum number of patients whom you have to follow to get these appropriate, scientifically appropriate result. And therefore, all these things has to be planned in advance before starting the research work. So whenever we conduct a sample size estimation, there are certain things which you need to understand. For example, whenever we cook, it's not like straight away we go and switch on the gas and start preparing the food. It's not like that, isn't it? Before that, we ensure that all the vegetables, all your pulses, everything are kept ready. All of them are taken and measured in correct quantities and kept aside. And then only you will go ahead with the cooking process. Likewise, before calculating sample size, it's important to understand that there are certain important prerequisites which you have to beforehand have in hand. Also, beforehand, you have to keep it ready before you go to a statistician to calculate a sample size. Many a times, if you know these parts, the calculation of sample size is just 2 minutes work or even a few seconds work, as I'll be able to show you in the subsequent slides also when we discuss in the subsequent during discussion period as well. So first, among the various prerequisites which we think about, the first one is the study design, whether it's a two-sided parallel arm study or a crossover study. The parallel study means when you do the intervention at the same time in the two groups. That is known as the parallel arm study. Whereas crossover study, it means that it's the same set of patients who receive, let us say, treatment A for a particular period, and then followed by that, they will have a break period, and followed by that, you will have intervention with drug B. So eventually, the same set of patients will receive both the drugs. Whereas in parallel group, the two different set of patients will receive the two different drugs. So that is important, the first important prerequisite. Next is hypothesis. We should always have an hypothesis in mind before you start a study or a trial. Whether it can be superiority trial, where you are trying to prove that one drug is much better than other drug. Okay. And the other one is non-inferiority trial. What do you mean by non-inferiority trial? It means that whatever new drug you're trying is not worse or is probably almost equal to the standard of care. That's what you're trying to prove. So that is the difference between superiority and trial and a non-inferiority trial. Now, once you understand this superiority and non-inferiority trial, next, what do you mean by hypothesis? Hypothesis basically is what you assume before conducting a research. As I told, hypothesis can be two types of hypothesis. One is null hypothesis, where you assume that there is no difference between the control and the study group. However, whenever you do a study, you start with the assumption that there is no difference with the study as well as the control group. Likewise, even if you are doing some 2 groups or 3 groups or 4 groups of involving 4 groups, you assume that all of them are equal at one point of time. That is what you understand by null hypothesis. And the next hypothesis, alternate hypothesis, where you assume that there is a significant scientific difference or significant considerable difference among the 2 groups, among the study and the control groups. And also, or maybe there is some association between the predictor and the outcome. This is what is understood by null hypothesis or alternate hypothesis. Most of the time, when we do any study, in our anesthesia practice, at least for our routine studies, we most often go with the alternative hypothesis, where we try to prove, start assuming that drug A is always better than drug B, or a technique A is better than technique B. So therefore, we start off with null hypothesis, or we start off with the assumption of a superiority trial. Once you understand what is your hypothesis, what is your study design, and what type of trial it is, next to the important prerequisite is to consider one primary outcome measure. Now, whenever we discuss about any study, invariably when you think about the study, you have two things. Either you will have one primary objective. Let us say you're trying to compare drug A with drug B. Invariably, drug A can have multiple effects. It can have effect on pain. It can have effect on hemodynamic parameters. It can have drug effect. Sometimes it can have some unwanted adverse effect. Let us say opioids. You can be considering you can consider opioid having analgesic property, its effect on hemodynamic properties, its effect on post-operative adverse events such as respiratory depression, nausea, vomiting, etc. So therefore, you might be having multiple points of a particular drug. You are not going to do the entire. You are not going to study the entire spectrum of things what the drug is going to produce. You are going to study only one part of that particular spectrum. For example, let us say you might be focusing only on analgesia. You might be focusing only on the adverse effects. You might be focusing only on the hemodynamic effects of a particular drug, though that has got multiple facets. So in that situation, so you focus on one thing and consider that one thing as your primary outcome measure. For example, if I say, if you're doing a study on post-operative analgesia, it's very important that you should define your primary outcome measure. So you can think about many outcome measures. For example, if you're doing a study on post-operative analgesia, you can see the outcome. How do you measure the effect of a particular drug on post-operative analgesia? You have to measure by using duration of an objective criteria such as duration of analgesia, or sometimes it might be 24-hour analgesic requirement, or even its effect on the VAS scoring. What happens before block, what happens after block, what happens before induction of analgesia, what happens after induction of analgesia. So there might be effect on VAS score or NRS score, or even for indirect measures. For example, suppose you are giving thoracic epidural and measuring PEFR. Indirectly, what PEFR says is how good the lung is expanding, and the lung is expanding because the patient is able to generate good inspiratory pressure because of decreasing pain. So it can be either a direct or indirect outcome measure, but you have to clearly define what is your outcome measure, and this has to be specifically mentioned in your research question. Once you mention that, so that's one example. If you let us say another type of a study. For example, you are doing a study on ICU outcome. So whenever you talk about an ICU outcome, it can be duration of ICU stay, need for mechanical ventilation, need for intubation, duration of hospital stay, or even percentage mortality. So just if you think that ICU outcome, it doesn't mean that you have to study the entire thing. You can consider one among them as one of the primary outcome measure, and it's very important to define that straight away in the initial part of the introductory part of your synopsis itself. And once you decide what is your primary outcome, try to quantify them depending upon what they represent, whether they are categorical or they are quantitative. For example, whenever we talk about analgesia, analgesic efficacy, and which is represented by duration of analgesia, you represented either them in the form of a mean or a median. So you quantify them. It's important to know the value of that particular thing. Suppose if you're trying to study some of the studies where you're trying to study the incidence of PONV or the incidence of dural puncture headache, something like that, where there you most of the time you don't mention the mean incidence of PONV or something. You actually represent them in the form of proportions. So you see whether how the primary outcome measures have been quantified, either in the form of a mean or in the form of a proportions. Once that is done, then we have next. So with this, we have come through two important aspects of prerequisites. So if we just think about a few examples to go with, for example, let us say there is a study of effect of dexmedetomidine on intubation response. So when you say effect of dexmedetomidine on intubation response is the question, research question. Obviously, when you say intubation response, it can be effect on the heart rate, it can be effect on the mean arterial pressure. Your primary outcome measure can be even changes in mean arterial pressure. So depending upon what you want to study, you can select either any one among them. For example, change in heart rate can be considered as a primary outcome measure, or change in blood pressure or mean arterial pressure can also be considered as one of the primary outcome measures. Once you consider one as the primary outcome measure, rest of the things you can have considered them as secondary outcome measures. Just I need to emphasize at this point that whenever you do any study, there has to be only one primary outcome measure, which has to be clearly defined initially. And the same thing, and the rest, all other parameters, though you are interested to study, you can study them, but they all become the secondary outcome measures. The reason why I'm telling this is because whenever you define one primary outcome measure, your sample size estimation is actually dependent upon the primary outcome measure. Now we'll go to the next example, comparison of static nerve block versus epidural for postoperative analgesia. So what are the parameters? The primary outcome measure can be time to 24-hour analgesic request, or time to first post-op analgesic request, that is your duration of analgesia. Or sometimes even you can consider, suppose you know that a sciatic nerve block will have lesser incidence of motor blockade when compared to epidural. So therefore, obviously, somebody who is having a fracture, you can mobilize him faster. So therefore, once you mobilize him faster, you're fast tracking the anesthesia. So you can consider even time to mobilization outcome measures there. So this is another example where somebody does a study of urethral graft on urethral strictures. So somebody can consider even success rate at 2 years, or operative time, or even blood loss, any of these things as a primary outcome measure. So likewise, let us see, there is a study which is being done in an ICO, considering the effect of different insulin formations on the incidence of on the control of blood sugars. So what can be the primary outcome measure? The primary outcome measure can be the degree of decrease in blood sugars from the baseline parameters after the administration. Or you can consider the adverse effects, that is incidence of hypoglycemia or incidence of ketoacidosis due to inadequate control of blood sugar. These can be considered as one of the primary outcome measures. So evaluation of a fluid therapy replacement bundle in an emergency trauma patient. So the primary outcome measure can be changes in simple things like changes in SBP and MAP, or even long-term outcomes such as incidence of mortality or hospital stay, duration of ICU stay, etc. So likewise, so therefore it's important to, what I am trying to emphasize is that we need to have one primary outcome measure, and we have to define that clearly. Next important, or the most important prerequisite when you calculate a sample size is known as the effect size. Now, what do you mean by effect size? It's nothing but the minimum difference the investigator wants to detect between the two groups. So, for example, you are doing a study where you are trying to compare drug A with drug B. So you definitely you say that to say drug B is better than drug A. What is the minimum difference between the effect of two drugs has to be noted? For example, you are comparing buprenorphine versus morphine. Both are long acting. To say which is better, and you are studying the effect, your primary outcome measure is duration of analgesia. So what is the minimum duration of analgesia difference which you consider is known as the effect size. So that is the difference what you consider to calculate the sample size is known as the effect size. Now, how do you come to know what is precisely how to know about the effect size? Generally, they are obtained from a pilot study, especially when there are no literature, absolutely zero literature available regarding that particular drug or that particular thing. And if not, if there are some literatures available, you can go through the previous studies, or you can use the clinical judgment and expert advice of a senior experienced anesthesiologist who is experienced in this particular field. For example, suppose if you are considering analgesic efficacy as one of the criteria for in your study, and you are trying to study the duration of analgesia between drug A and drug B, so we can consider a minimum of 30 minutes difference between in the duration of analgesia between the two groups to be clinically and statistically significant. This is, see, let me clear at this point that this is only our assumption. It's not necessary that in your study, the difference has to be 30 minutes only. Difference can be 30 minutes, it can be even 200 minutes. It doesn't matter. But you, by putting this particular sentence, what you are trying to tell is to make, to say a drug is better than drug B, there has to be a minimum 30 minutes difference between the two groups, which so that you can make it, you can say that it is clinically relevant or clinically significant. That's what you are trying to assume, and that's what you are trying to put forth by assuming an effect size. Likewise, whenever you consider proportions, let us say effect on PONV, drug A and versus drug B, at least there has to be a minimum difference between the two groups of 30%. We have to assume minimum of 30% between the two groups to say drug A is better than drug B. So the next prerequisite is variance. So what do you mean by variance? Variance is nothing but the degree of deviation. That is, I already explained in the previous slides that whenever you take about one primary outcome measure, with that primary outcome measure, you quantify them with a particular number. It's not necessary that the number can exist in all the patients, the same number can come as a result. There can be some variation. For example, somebody can have a duration of analysis of 30 minutes, somebody can have 40, somebody can have 60, like that. The variation can be there. Now we have to measure the variation, and that also we have to assume here. Usually these are again obtained from the pilot study, most of the time, especially when the study is new study or some from previous studies. Usually standard deviation is considered as one of the variant, is considered as a variance for continuous variables, and that is when that is the only thing what is required. Now, one practical point I'd like to share here is, suppose you are finding it difficult to enter a particular value for variance while calculating the samples. What you can do is, if you have a previous studies, let us say drug A, you are trying to compare the duration of analysis with the drug A, and there are 2 to 3 studies which have shown, which have already done duration of analysis with particular to that particular drug. So you can take the values of them, you take the mean and standard deviation values of them, and the variance is calculated by taking the average of the standard deviations of the two studies. Average of the standard deviations of the two studies. So therefore, if you consider like 30 plus 60 divided by 2, so the variance what you can feed is 45 minutes. So this is just a group exercise. So we can see there is a study of comparison of morphine with placebo for postoperative analgesia. The previous two studies, the duration of analgesia in study 1 was 450 plus or minus 65 minutes, whereas group in other study it was 385 plus or minus 85. Now, how do I get the variance to be entered for my sample size calculation? I simply take the average of these two. 65 plus 85, it's 150 divided by 2, 75 minutes. So this is the variance what I am going to enter in my formula. And next important prerequisite is alpha error or type 1 error. Type 1 error or alpha error is nothing but it is the error that occurs when null hypothesis is rejected when it is true. That is, whenever you say that there is no difference between the two groups, actually or scientifically, there is no difference between the two groups. However, due to some inherent patient factors or inherent study design factors, there suddenly crops up a difference between the two groups when actually there is no difference, or when scientifically there is no difference. That error is known as alpha error. It represents the chance of a researcher detecting a difference between the two groups when in reality no difference exists. That is it is in other words explained as false positives. The next is the type 2 error or beta error, where null hypothesis accepted when it is false. Actually, there is a difference, scientific difference between the two groups, but due to patient or inherent factors, you don't find any difference, and you just that you don't find any difference. This kind of an error is known as beta error. So this does not detect the difference between the two groups when in reality the difference exists. So this is in other words explained as false negative. So type 1 error is false positive error, whereas type 2 error is false negative error. And the complement of this beta error is nothing but power of the study. So most of the time we use power of the study to quantify the quality of a particular study. So if you see this example, it's very simple. So a clinician telling a male that you are pregnant. So this is actually type 1 error. Whereas a fully pregnant woman say, the clinician saying fully pregnant woman that you are not pregnant. This is type 2 error. Generally, we always the error rate of alpha error, that is a type 1 error, is customarily set lower than the type 2 error. The philosophy behind is that the impact of a false positive error is more detrimental than the false negative error. Now, to elaborate on this, generally what we do is we keep a alpha error or type 1 error at 0.05 and type 2 error or beta error at 2, or in other words, power of 0.8 or 80%. That is what is meant by alpha and beta error. So now why you want to keep alpha error as low as possible is because you are unnecessarily causing a damage. Suppose if there is no difference between the two groups, but you find a difference and you propagate widely saying that this particular drug A is better than drug B, and this drug A will be rampantly being used among the clinical subject, among the patients in the clinical practice without knowing the side effects of this particular drug, and it can result in a very devastating consequences. That is why it's always important that you keep alpha error always as low as possible and beta error at around 2. So once you have all these prerequisites in hand, so if you just to summarize, what are the prerequisites? I can just quickly go through some of the prerequisites. Number one, you need to know the study design. Then you should know whether what is your hypothesis, null hypothesis or alternate hypothesis. And then next thing what you need to know is what is your primary outcome measure. And once you know your primary outcome measure, you quantify them using a mean or a proportion depending upon the parameter what you are going to use as an outcome measure. And then once you know all these things, then you think about what is an alpha error, what is the beta error, and finally, but not the least, it's the effect size, or what is the minimum difference you are going to anticipate between the two groups. That is known as the effect size. So having all these ingredients in hand, now what you do is you just apply these values into various formulae that are available for calculation of different types of sample size, and then you get the value. Nowadays, we generally don't depend on the formula because most of because of availability of n number of online softwares for calculation of sample size. So these are some of the things what you need to keep in mind. For whenever you are using sample size calculation based on your mathematical method, these are some of the things what you need to keep in mind. So these are some of the formulae which are available for calculation of sample size. So the representative values for these things are available in this table. However, I'll be talking more about the online sample size softwares, like we have powerandsamplesize.com, openapi.com, Stata, SPSS, and also we have sample.net. So, and even NMaster, this is one of our own Indian software which is developed by CMC Vellore, and it's quite quite exhaustive and well covered. So we can use that also. But only thing is it's available online. So once we have considered all these things, now we'll just quickly go through few of the examples. So let us start with a simple example. Study of effect of dexamethasone as an adjuvant to bupivacaine in supraclavicular block. So the primary objective here, as you all know, it's a parallel arm study. And second thing is here it is alternate hypothesis, where we feel that dexamethasone is going to improve the duration of analgesia. So therefore, the primary objective will be duration of analgesia. So once you know the primary objective, you can represent them by using a particular quantitative, in a quantitative way. So here we represent it by duration of analgesia was, from a previous study we got a value where the duration of analgesia was 345 plus or minus 45 minutes with a dexamethasone and 265 plus or minus 30 minutes with placebo. So this is what we obtained from the previous study. So effect size here, what will be the effect size? It is the minimum difference that is to have to be clinically significant. Generally, we can consider, let us say 30 minutes. Therefore, we assume that the addition of dexamethasone, we are not, I need to highlight at this point that we are not considering this value of 345, but we are actually assuming a much lower value because it's not always necessary that the patient will develop the same number, same value in different, when you conduct the study at different places. So therefore, to be on the safer side, we try to assume a minimum safe value or minimum safe value which can be clinically significant. So therefore, we add an effect size of 30 minutes to the placebo group. Why I'm taking placebo group is here is because this is most of the time well known. That means without dexamethasone, you do any study with a particular dose of particular bupivacaine, this particular values, you know that more or less the value revolves around this number only. So therefore, that's why we take this number as the reference for us, and we assume that by addition of dexamethasone, another 30 minutes of duration of analgesia is added. So therefore, by addition of dexamethasone, you will get approximately around 295 minutes when you have a 265 minutes duration of analgesia without addition of dexamethasone. With this, and then we add a variance of 45 minutes because we can straight away take the variance from the previous study, as I told in the earlier study. The standard deviation can be considered as a variance. So considering all these things and considering a power of, as I discussed earlier, we conventionally consider a power of 0.8 for all purposes and alpha error at 0.05. So considering all these things, once we have these values in our hand, we just go to one of the any of the softwares, but what I generally use OpenAP software, which is a WHO software. In that, if you open this website, you just click this is the opening page that appears. In this page, you click on the sample size here, and then a drop-down menu occurs like this: proportion, unmatched CC, cohort, and mean difference. And that you click on mean difference, a page like this opens where you can see so many aspects. That is, you see start, enter, etc. This is just an example. It shows how to enter the data. So here there is something called confidence interval, where confidence interval is nothing but the reciprocal of your alpha error. So your alpha error is 0.05, then you enter 95 here, 95%. If your alpha error is 5%, you enter 95% here. Likewise, power, you keep it at 80 as per a standard thing. And then ratio of samples between group 1 and group 2, you consider as 1. Like you want equal number of patients in both the groups. So you consider the ratio as 1. And then whatever mean and standard deviation we calculated from the study. Actually, if you notice from the previous, in the previous example, I just go for your sake. So here we can notice that with placebo, with the bupivacaine alone, it was 265 plus 30. And we assumed that by addition of dexamethasone, it will be 295 and the variance can be 45 minutes. So we just enter those values here once again. Here you enter 265 plus standard deviation of 30. That is the placebo group. And then dexamethasone group, what you assume, that is 295 plus here you enter a value of 45. That is the variance what you assume. And then once you click on the new data and enter all these details, and then you click on calculate. So automatically your sample size will come. I wanted to show this live, but unfortunately because of the net instability, sometimes it might not be visible. That's why I'm not doing this. If time permits, I'll definitely do that and show you. So this is one way of calculating sample size for your routine quantitative data. That is, for example, something like, suppose if there is, you are calculating sample size for proportional data. Let us say, for example, this is one example we can take. Comparison of magnesium sulfate versus dexmedetomidine. Sorry, this is again the same thing. Let us say the next thing. Study of effect of magnesium sulfate on requirement of mechanical ventilation in organ transplant patients. Here, the primary outcome I can define as the percentage of patients requiring mechanical. That is, how many of them require intubation. So the previous study, number of patients requiring ventilation in the control group was 60%. That is 60% of the ICU admissions in the, of OPCP in the last month, 60 of them required intubation and mechanical ventilation. So what is the effect size? As I told, effect size is at least there should be at least 30% reduction in this particular 60% to say that magnesium is significantly effective in reducing the mechanical ventilation requirement. So anticipated incidence. So therefore, anticipated incidence of intubation in magnesium sulfate group would be 60 minus. Now 30% reduction is what I'm trying to understand. So 30% reduction of 60% will be 30 by 100 into 60. So therefore, it will come up to 15. So 15, sorry, 18, it comes up to 18. So 16 minus 18, it will come up to 42. So the anticipated incidence. So therefore, assume that by giving magnesium sulfate, number of patients who would require intubation in spite of receiving magnesium sulfate would be 42. And how many, the number of patients who 42%, whereas number of patients without magnesium sulfate will be 60% who require mechanical ventilation. So keeping these things in mind, and power and 80, power and alpha error at 80 and 0.05, I go ahead with the calculation of sample size. So I just open the OpenAP software, click on the sample size, and then here we have to go for cohort bar RCT. Click on the cohort bar RCT. So you will a page like this will open. In this, you click on the enter new data, and then you will come across two-sided confidence interval. That is your alpha error. You enter at 95 because your alpha error is 5%. Then you enter power of 80%. Then the ratio of exposed to unexposed groups, you keep it at 1 because you want equal number of patients in each groups. Now, the next line comes as percentage of unexposed with outcome. That means those who have not received magnesium sulfate, and the outcome is intubation. So those who have not received magnesium sulfate requiring intubation, as per our previous study, we enter 60 here as per our previous calculations, and then leave out this odds ratio, and then percentage of exposed with outcome. That is how many of them are exposed, how many of them are receiving magnesium sulfate, and what is the anticipated incidence of intubation in them. So that will come up to 42%. So you enter 60 here, you enter 42 here, and then click on the calculate. You'll get the sample size. So it is as simple as that. So what I need to emphasize at this point is, it's important to understand that you should always have a primary outcome measure, and then you should always have an effect size. You should have a proper effect size. Then you assume a proper alpha and beta error, and also you should know what is the study design and also what is the hypothesis. With this, you can have all these values and enter into the software, or within matter of few seconds you will be coming across the statistics, sample size calculation. So these are various examples. Now coming to a different type of example, let us now, all this time we are calculating study sample size for interventional studies. Now observational studies, let us say that there is an incidence of prostatic carcinoma. You want to try to find the incidence of an incidental prostatic carcinoma in patients undergoing TURP for BPH, especially with elevated PSA. So in the previous study in USA, they found that the incidence was 12% among one particular hospital. So, and now what do you mean by population here? Population here is the number of patients who have BPH with elevated PSA. They form the population. So this can be obtained by your previous hospital records, like how many patients with BPH with elevated PSA came to your hospital. And assuming the incidence of 12% from another study. And also there is something called precision here. Precision means it is the range within which you expect the result to be in your study. Excuse me. So precision is the range within which you are expecting the number to be. For example, your estimated percentage is 12%. You have a precision of 5%. That means you expect the result anywhere between 12 minus 5 is 7, 12 plus 5 is 20, 17. So you are expecting a result anywhere between 7 to 17% in your study. So with these assumptions, if you go, you can calculate the sample size. So once you calculate the sample size, does it end there? No, it doesn't end there, because many times when you conduct the study, some of them may violate protocol, some of them may not withdraw themselves after initial consenting, etc. So they are known as dropouts. They can be subjects who may opt out after enrollment, patients not receiving allocated treatment due to various reasons, or patients removed from the study due to violation of protocols. They are all considered as dropouts. Now you have to compensate for that so that your sample size will, all these things will not affect your final outcome of the final results. So therefore, you add another 10 to 15% of your total calculated sample size to get an additional final sample size. So therefore, your final sample size, let us say if your sample size calculated is 25, you add another 10% of it. for 10% of 25 is 2.5. So you cannot use 2.5. You increase it to the next higher integer. So you increase it to 3. So therefore, your final sample size will be 28 patients, not 25, because these 3 patients are required to compensate for the dropout. So therefore, your final sample size should contain the calculated sample size plus the dropout compensation. So once you've done everything and you've done a study, everything, then you write in a paper. A sample of 24 units in each group would be required to keeping power or 80% and confidence to 90%. We included 35%. Is this correct? No, this is not correct because it doesn't give a complete information. So the better way to write it is assuming a duration of analysis of 150 minutes and standard deviation of 15 minutes, keeping power at 80%, confidence interval at 90%, where you are mentioning the primary outcome measure and you are considering what all values you consider for the calculation of sample size, and also what power you consider, what this one you consider, and what effect size you consider. Minimum of 20% difference. So the effect size what you consider. A minimum of sample of 24 patients would be required, but you add 27 patients to the final sample size to compensate for dropouts. So if you write this way, the editor will know that you have actually done the work properly, and the chances of rejection of paper are less, especially based on the sample size estimation. So having done this, now there is always a lingering question by many of the authors, like, do you really require to do a pilot study? Of course, pilot study is required only when pilot study is done, usually to test the feasibility of a particular protocol. This is mainly for very large scale studies where you are using more than like 1,000 patients or something like that. So the main thing, the purpose of doing pilot study is feasibility of protocol, to see the acceptability of the procedure of the drug, and to ensure randomization, to practice and ensure randomization and blinding. And also, it also helps in selection of an appropriate outcome measure. Sometimes you would have selected something else as an outcome measure. And once you do a pilot study, you might find something else can be used as a primary outcome measure. So to selection of a appropriate outcome measure, and also for calculation of sample size, you require pilot study. But when do you do a pilot study? You do a pilot study only when there is no evidence available for the intended drug or procedure. You just, let us say you are using buprenorphine 1 microgram. There is various studies which have published with buprenorphine 1 microgram, but you are trying to do a study based on 0.5 microgram per kg body weight. So at that point of time, the pilot study is not required for 1 microgram. It's only required for 0.5 microgram. If there are no studies, I mentioned, if there are no studies published in the entire literature with the use of drug of 0.5 microgram per kg. If it is used for post-operative anesthesia, the same value can be used for your other purposes. So therefore, don't just go on doing and quoting that you have done a pilot study. Pilot study should be done only when there is no literature available at all. So whenever you do a pilot study, one important consideration you have to keep in mind is that pilot trials often estimate the standard deviation parameter imprecisely, and therefore certain correction parameters have to be applied before you calculate the final sample size. And and many times there is the next question which comes is, how do you need to calculate a sample size for pilot trial? Till now, there is no literature or there is no evidence in the this one which says that you have to calculate a sample size for pilot trial unless it is incorporated within the main study. So as a flat rule of thumb, most of the articles do say that you can enroll around anywhere between 10 to 70 patients as a pilot trial sample. Again, this one depends on availability of adequate number of patients, knowledge and evidence of safety profile of a drug or technique, and also it also depends on the type of outcome measure what you're trying to study. But important points to be considered is whether it is a null hypothesis next. So these are the important things what you have to keep in mind with regards to pilot trial. And now coming to calculation of sample size for correlation studies, what we are doing of late. We are trying to correlate between hemodynamic profile and the drug volume, hemodynamic profile versus the patient demographics, etc. In such situations, so it's more or less the similar like whatever I described. Here, a small thing is correlation coefficient has to be considered instead of estimate or a values from a previous research of correlation coefficient has to be considered instead of an effect size, and the rest of the things are almost same. However, as a thumb rule, it's we can consider a correlation coefficient if there are no studies which are published with regards to correlation of parameters what you are trying to study. You can consider a null. If you are considering a null hypothesis, you can use an estimate of 0.2 to 0.3 as a correlation coefficient. Whereas if you are considering as an alternate hypothesis, an estimate that which can be considered for calculation of calculation of sample size is a correlation coefficient of 0.4 to 0.6. So thank you for your patient hearing.
Thank you, Dr. Sudhis. I think it's a very good informative session. We
Thank you,
have a few questions in the chat box.
Yes, sir. Yes, sir. I am ready to answer that, sir.
I'll just say those things. Yeah. So many have the doubt regarding this pilot study. So how useful it is? Already you have explained several times. So we have a question on the pilot study, because in the last meeting also there was a issue that in case only if it is necessary you go for a pilot study. Otherwise, keep inquiring, keep doing more depth review of literature to find out the required data. So would you like to speak few minutes on this importance or usefulness of pilot study in what scenario and how the students should go about this?
Sir, this is a very important aspect. Actually, that's what even I've been facing as an editor many times. They do come with, they mention that they have done a pilot study. But what is important is there has to be a thorough search of literature before you go for pilot study. Only when there is absolutely no studies available in that particular thing, then only we can consider a pilot study. For example, now many times what happens, sir, actually some of the authors would have mentioned in the literature in the introduction part that few studies have been done where this buprenorphine is compared with the buprenorphine, and they would have mentioned that, and they have quoted the reference also there. And when they come to the sample size calculation, our sample size was calculated based on a pilot study. So which actually is little, I mean, that is the wrong thing. Already they are contradicting their own point. They have already in the top part, in the introduction part, they have already told that there are some studies which have published with that particular drug. But again, when they come down and for calculation of a sample size, they say that there is no, I mean, there are no studies. That means they are contradicting their own review of literature. So that should not be there. So they have to do a thorough search of literature, and only when they find no literature available for particular thing, then only they can go for a pilot study. Now the question arises, sir, they might be saying, sir, sometimes we have done a study on, let us say they are doing a study on post-op analgesia. In most of the studies, the morphine used is 3 milligrams. Now I want to see whether 1.5 milligrams is effective or not. That's what they are trying to do. So that's why they are doing a study. In that case, actually what will happen, and they say that there is no study which is published which says 0.5 milligram is 1.5 milligram for post-op analgesia. But if there are no studies available, then probably what they can think is they can go for a pilot study involving only 0.5 milligrams, maybe involving some 5 or 10 studies, 5 or 10 subjects, and see for the sake of getting the mean and standard deviation. So so that is the thing. So otherwise, suppose if somebody is doing a study of let us say 1.5 versus 3 mg of morphine, as I told earlier in the previous example, and they find that is for the sake of let us say they are trying to find out the incidence of post-op nausea vomiting. Then but they found a study where they have compared 3 mg versus 1.5 mg for duration of analgesia, and the incidence of side effects in them they noted was like 2% versus 3%. They can still use that data for the calculation of sample size, and they need not do a pilot study there. Pilot study has to be done only when you are using whenever you are not sure about your availability of literature in spite of an extensive search. Only then there comes the role of this pilot study.
Thank you, Dr. Sudesh. I think you are loud and clear. One more question or two participants want to know about sample size calculation in an observational study. There are
Yes,
two
sir.
questions on this. Both are similar. So,
Uh-huh.
like somebody, instead of doing an intervention, you want to see the preoperative sodium level and the percentage of people who get admitted to the ICU. How to go about the sample size for that?
Pre-op sodium level and the incidence of, yeah. So this one is actually, it's an observation study. So I just need to go through that question. Want to know, like, for example, pre-op study sodium level and incidence of post-op ICU admission. So here, what they can do is they can see if there is any previous literature where let us say, in a post-op, they would have seen all the post-op ICU admissions, and then they have found out how many patients had decreased sodium level at the time of admission. You can use that as a this one, sir. And to that, as I told in the last example of a sample size calculation, that is where you see the number of patients who are getting admitted to ICU. That will be the population and what is the previous incidence in the previous study. That is the pre-op number of patients in the post-op ICU admission who came with a baseline low pre-op sodium level. So you see that from the previous study and add precision to that, as I told, like 2 to 5% precision, and then you can enter that in a formula and calculate. For example, sir, if I can share the screen, I don't know how much it is helpful, but I can show them the example on this one, and then I can try to.
Please share the screen. No problem.
Yeah. I'm sharing the screen. So here I opened the openepi.com. I don't know how many of them will be able to understand that, but anyways, I'm trying to make that FA. So I go here, I opened openepi. In that I clicked on the sample size and I clicked on proportion. So if I open that proportion page, you come across a page like this. So where you have population size, anticipated frequency, etc., etc. So I click on that, enter new data. Here the population, there is something called population size. Population size will be the number of patients who are admitted to our ICU, or if you are doing a study which is applied to a general population size. So then you can enter a particular large value, something like 1 million or something like that. And then now next there is the next line says anticipated frequency. Now anticipated frequency is the thing. For example, as the doubt arose, what is the percentage of, what is the incidence of pre-op sodium, low sodium levels in all the ICU admissions? So let us say it was in a previous study, it was around 15%. So I enter an anticipated frequency of 15. Then absolute precision is the next thing. Absolute precision is nothing but the range within which I am expecting the value. For example, you can keep it at 5 or 10 or 15 depending upon. Now there is one thing what I want to tell when you think about an absolute precision. Suppose if you are studying something which is very commonly occurring, so it's always better to keep the absolute precision as low as possible, because you the problem is there is a possibility of wide variability of the outcome. So therefore you keep an absolute precision of 5%. Suppose you are finding a very rare outcome. Let us say, for example, what is the incidence of let us say post-dural puncture headache among spinal patients receiving spinal anesthesia? Nowadays that is not a common incidence. It's quite a rare incident. In such a situation, you actually change the absolute precision to, rather than keeping 5%, you can keep it at 10 or 15%. So therefore, that is one thing what we have to keep in mind when we enter the value of absolute precision. So, and then there is something called design effect. Usually we keep it at 1 when we are only comparing two different, only two outcome parameters. So if I click on calculate, if you can see, there is a wide range of numbers available. So that is, if I see, I'll just read out what is it is showing. 95% confidence level, sample size 196. 80% confidence level, sample size 84. This is the thing what's appeared on my screen. Now that means what I'm trying to tell is, if you want to detect an error of less than 5%, alpha error of less than 5%, your sample size should be 196. If you accept an alpha error of 20%, then your sample size is 84. As I told, and as if you see that as a confidence interval goes on increasing, the sample size also goes on increasing. That means if you want to reduce this error, you have to include more and more patients. For example, if you see, if you want to keep a confidence error, a confidence level of 99.99%, that means if your error has to be less than, if your error has to be 0.01%, your sample size is almost 772. So this is how we calculate the sample size for observational studies, like what the concerned person had asked.
Yes. One more question is there, that whether the secondary objective from a previous study can be considered as a primary objective in the current study, and sample size can be estimated based on the secondary studies findings.
Definitely, sir, that can be done. That definitely can be done, because that acts as a pilot study for our study. That acts as a pilot study for our study, because in the second, the thing is, in their secondary outcome measure, that might not be suitable. I mean, they will not be able to comment based on their secondary outcomes in their study. But we can use those values for calculation of sample size of our study, and we can consider them as a primary outcome measure. Let us say somebody has done 24-hour analytic requirement as a secondary outcome measure, and duration of analysis as primary outcome measure in the previous study. And now I want to assess the secondary 24-hour analytic requirement as the primary outcome of my. I can easily use that data, whatever the previous study is available, and I can calculate the sample size based on that. That's definitely possible. In fact, that's the way it is. That's the way we are supposed to go ahead.
A bit different questions. That is a ethical committee approval required for a pilot study?
Sir, it depends on many times. Ideally, it is not.
All studies requires ethical approval.
Ethical approval.
Pilot study, so it's a study, and it is being different. So all studies, irrespective of whatever, if you are doing it as a study, then it will require ethical approval. And if you are doing differently, when we report as a case or a case series, and you are not taking it as individual case, a patient consent should be there that you are using a different strategy or a different standard of care, which is not routinely applicable. But if you are following a series of cases, even for that, ethical approval would be required for even for publication. Sometimes when you do a retrospective series analysis, even then ethical approval is required, where you take an ethical approval, but the consent is waived off. Human interventions. Over to you, sir.
Yeah. So this, I have a doubt, a little bit more clarification.
Yes, sir,
looking for a cohort study, like prevalence of a particular, like I want to see what would be the incidence of chronic pain after laparoscopic cholecystectomy.
Yes, sir.
So how many patients I should ideally enroll so that I can see a reliable or a results which can be generalized to the public?
Sir, as I told in the previous study, again, it's an observational study. Suppose if you have not, let us say you have not got any literature regarding this. Suppose if you have not got any relevant paper till now which is published, there is no paper which has tried to find out the incidence of a chronic pain, then what we can do is we can follow up around 20 or 30 patients, and 20 or 30 patients we can follow up, and among them, what is the incidence we can find out, and that incidence we can use as a baseline marker for our study, and that can be entered in the same formula what I showed in the previous lesson, sir, where we enter the anticipated incidence, we enter the population size, we enter the anticipated incidence, and also we consider what is the precision, and based on that we go ahead with the calculation of sample size.
Yeah, most of the questions are related to same retrospective study and observational study only. I think you are clear. So you mean to say that the total population that need to be considered is 1 lakh?
So that is only in case of a this one, sir. What do you say? We consider that as a total population. Like when you are applying the study for a general this one, what is general population? There is something called general population and study population. General population is the universal population, what we talk about. Study population is the population. For example, let us say now you are very specific. For example, you are doing a study of incidence of now you are talking about laparoscopic cholecystectomy now, sir.
Yes.
So here the population will be all the patients who are undergoing laparoscopic cholecystectomy in your institute. For the sake of this one, what you can consider is if you are having, let us say, an annual in your last 1 year, you anesthetized around 4,000 patients for laparoscopic cholecystectomy last 1 year. That will form the population for your population base for your study, for your sample size calculation. Because your study is basically, because your research question is basically involving the patients undergoing laparoscopic as the population. So that is why here comes the role of our picot and finer, what we discussed earlier in the previous classes. Like in the Dr. Balmaskar sir and Harsu sir classes, we always we define, whenever we form a research question, we involve that picot criteria. That is, we have to include population, we have to include intervention, we have to include outcome, and we have to include the comparator, and we have to include the timeline. So the population, whatever we define there, will become the population for our sample size calculations.
Yeah. One more question is there. What is the concept of effect size calculation for non-inferiority study?
That I told, that I've answered, I think, sir. Actually, non-inferiority means you mean to say that the let us say example. I'll take an example of a regional block, sir. We are routinely practicing, let us say, thoracic paravertebral block for breast surgeries. Now suddenly, this erector spinae block has come. Now suddenly somebody wants to say that erector spinae block is as good as paravertebral block in providing postoperative analgesia. So that means you are saying erector spinae is not inferior to paravertebral block. So that is known as a non-inferiority trial. So if to say that they are almost equal, the effect size should be as minimum as possible. So generally we consider an effect size of 10 to 20% to say that it is non-inferior to the new technique is non-inferior to the older technique. So we consider an effect size of around 10 to 20%. You can even consider, but the thing is, as the effect size increases, the sample size decreases. As the effect size decreases, the sample size increases. That is what we have to keep in mind. So therefore, we have to be very scientifically clear in calculating. One thing is regarding effect size, what we need to remember is whenever we calculate effect size, we assume an effect size, and towards the end of the study, you complete the study and you see the result, everything. If the effect size, whatever you have assumed, is higher than what is seen in the result, then again the power of the study will come down. So therefore, we have to be very careful while calculating the while assuming the effect size in our sample size estimation. We have to keep it as low as possible, as low and as clinically relevant as possible, so that your effect size, what you see in the results later after completion of the study, is not lower than the effect size what you assumed during the conception or the inception of the study.
We have one more question. Which one is preferable for drug comparison, superiority, equivalence, or non-inferiority trial?
Sir, it all depends. It depends, sir. The problem thing is, if you are trying totally new drug, which has got no, there is not much of study which is being done. It's always better to go for safety and efficacy trial. That is our phase 1, and then later, once the drug has come into the post-marketing, after marketing, after phase 1, phase 2, phase 3 trial, everything, when it has come down, at that point of time, we can always go for superiority trial. But initially, it's always better to go for non-inferiority trial. But having said that, if we already, by reading the pharmacokinetics and pharmacodynamics of the drug and everything, we know, and also based on the animal studies, we know that this drug has got probably little more effect when compared to the standard existing drug, then straight away we can go for superiority trial.
one more question is there, how to assume a population size for observational study involving NOR block?
Sir, again, that's what, it
It's
depends on
simple.
how many,
Yeah, for example, already you have explained with erector spiny block. Somebody want to do a brachial plexus block.
yeah. So it's always, sir, can you please come back to the question?
Yeah. How to assume a population size for observational study?
Yeah. So yes, sir. So in that case, already I told, like now you are planning a regional anesthesia technique. So obviously, all the patients who come or who are fit for that particular regional anesthesia technique, it's not necessarily that you follow the same technique in them, but all of them who are fit. Let us say you are planning, as you said, sir, if you are planning for an interscalene block or a supraclavicular block, we generally give it for upper limb surgery. So all the patients who come to your theater in the last 1 year for upper arm block, upper arm surgery or arm surgery, they are all considered as the population for your study. Let us say in the last 1 year, you have done around more than 1,000 or 2,000 fracture humerus, all put together, not only fracture humerus, fracture ulna, fracture radius, or even your distal phalanges, whatever it is. If the number of patients with fracture upper limb is around 400, they form your basal population size. And based on that, you calculate the sample size for your particular study, keeping the incidence and the precision.
We have a suggestion from Dr. Balbhaskar sir.
Yes, sir. Yes, sir.
He suggests the students should understand the inputs while putting the actual input into the software. And I think OpenAP has in the footnote tried to define each input. And
Yes,
the
sir.
students should go through that before putting the input, and that is better while before using the software. And sir has also mentioned, Balbhaskar sir, one more
Yes,
regarding the pharmacokinetics and also pharmacodynamics as per the evidence points.
That has to be considered when somebody decides whether it has to be superiority or inferiority. I think sir is there, sir. Sir, good evening, sir. Good evening, sir.
Good evening. Sorry. No, that was a question related to superiority and inferiority or equivalence trials. How to decide? So whenever we go into the evidences in the published literature, if a drug has got similar pharmacokinetics or the same family, duration of action and elimination, some of them are already known. So if such is the case, then we can decide whether it is an equivalent study or you want to have a non-superiority trial or non-inferiority trial or superiority trial per se. So ultimately, it's our own knowledge and information which we get from the literature search, which should guide us on deciding which should be the type of trial related to comparison of the two drugs. That was what I wanted to convey. It's like, for example, I want to compare, very simply put, I want to compare paracetamol with something like ibuprofen. I'm talking about the very most basic things. So both are analgesics. So I want to compare. So if paracetamol is going to act for about 8 to 12 hours, and if, for example, ibuprofen is going to act for 8 to 12 hours, so there is, you can say, okay, they are almost similar. Which is superior or which is both of them are equivalent. That's how we try to compare them. So that's a rough, explanation from my side. So that's the way it is. Like I cannot compare between, for example, imagine a morphine analog. Somebody comes out with a morphine analog which has got long duration of action. So at the other extreme, I should not be comparing with, for example, remifentanil for the patient, or even fentanyl. So, and I talk about ondansetron and palonosetron. Okay, so then I will definitely say palonosetron would be, I will assume that palonosetron will act for a longer time. That's a benefit in cases where you want anti-nausea, anti-emetic effects for more than 24 hours or more than 48 hours. If I want something for a surgery less than 24 hours, I would only talk about ondansetron. So when you compare also, like it should be, it's not like apples and oranges. Even here, if both are oranges, two different species of oranges, it could be a superiority, non-inferiority or non-superiority or equivalence. So I hope that's the way is the meaning. Thank you.
Yeah. Thank you, sir. Dr. Sudhish, we have one more question.
Yes, sir.
Dr. Imran want to know which is the best software for calculating the sample size. I feel so long the input is same, all software will be giving almost similar
Almost same. Yes, sir. Yes, sir.
sample size
Yeah.
estimation.
Yeah.
So,
Ultimately,
anything
it's the
say,
same. Yeah. Then there was one question, sir, in this one by Dr. Rinsu.
Yes.
They were asking how to increase the significance without, apart from increasing the sample size.
Yes.
They just need to understand that we are not going to increase or decrease significance. We are only going to conduct the study as per standard protocol, uniform protocol, what we initially decide. We have to follow that protocol and conduct the study and enter the values honestly and sincerely and allow the results to come by itself. We should not try to go on increasing the sensitivity and specificity, or we are no persons to tamper the outcomes by doing something and all. So therefore, there is nothing that what you need to understand that we have to calculate proper scientifically calculate the sample size based on the previous studies, etc. And then do the study accordingly and leave the results to declare by itself. We should not try to increase or decrease the significance here.
Yeah, we have one more suggestion from Dr. Padmaja. She says the hypothesis should determine what we should use, superiority or equivalence, and this should be defined a priori.
Yes, sir. Yeah, I totally agree with you, madam. I 100% agree with you. Correct, ma'am. Correct.
Now I hand over to Dr. Rakesh Gar, our chief editor, IJ, to further add if anything is there. Dr. Rakesh. We have senior person Dr. Chakra Rao sir. We request your suggestion regarding the program and regarding the topic today, how we can improvise on this.
Good evening.
Chakra Rao sir, you are in mute, I think. You are in the mute, sir.
Just to
We request your suggestion.
what you are talking, that's all. Thank you very much.
Dr. Rakesh.
Yeah, thank you so much.
Editor-in-Chief, IJ, now I hand over to you.
Thank you so much. I think it was a wonderful interaction and comments from everybody. So many of the key messages there. So the type of articles that we do get, almost 100% of articles that are being received by IJ do not need a pilot study. So they are already data, the type of article we are receiving. So please do not quote for the pilot studies and mentioning the reference here. Again, I will reiterate that all articles, all human studies must have an ethical approval. And I reiterate again also that all must be CTRA registered. So these are the two requirements from the IJ which should be taken very seriously and mandatorily, which is required for all the patients. And do quote whatever Dr. Sudhish and Dr. Aloka in their discussion has mentioned. You need to mention these details into the last section of your method section, that how exactly the sample size was calculated. It is mandatory requirement of your initial submission. So all details, whatever he has talked about, the 95% CI, the power, the alpha, these data that which you have used, the precision you have used, or the assumption you have used, whatever you have, it should be mentioned clearly with the reference for publication purpose. Anyhow, thank you so much. It was a wonderful session. I hope all the members would be benefited. And I'm sure I'll be seeing some interesting manuscripts with the details they have discussed. And I'm sure that this will be helping the future bidders. I will also request all the participants who are listening. Many of the manuscripts which we received are a part of dissertation and thesis. So I will suggest that many of you will be the teachers' guides to them. You can share the link of the IJ webinar to your students also. It is open to everybody. So that while they are writing the protocol or while they are writing the thesis, And while they're writing it for publication, they are aware of these nitty-gritties which are being discussed every alternate Thursday, 5 to 6 p.m. And these are very mandatory requirement for all publications. So I hope this will be helpful to all of you. And I hand over to Dr. Kiran Mahindru for the final vote of thanks.
Yeah.
Thank you, Dr. Sudesh and Dr. Alok, for the lucid presentation. And thank you for resolving the queries of all the participants. So with this, we'll conclude today's webinar. And the next webinar will be on 6th of July. Thank you so much, everyone, for joining.
Thank you, sir.
Thank you. Thank you.
Thank you.
Sir, thank you, Sudesh.
Thank you,
You
sir.
have done a wonderful job.
Thank you, sir. Thank you very much, sir.
Thank you, Sudesh,
Thank you, Alok, sir.
Dr. Aloka, for a wonderful discussion. I think many queries were solved. So it
Thank
must
you,
be
Dr.
very
Rakesh.
useful
Thank you.
to-
Yeah,
Thank you. Thank you all.
thank you.
So I'm leaving the session.
Yeah, thank you so much.
Thank you,
Sir.
sir.
Thank you so much.
Should end.